So it sounds pretty simple. You get the patients enrolled in the social health insurance program, and then they can go to the clinic and get their drugs. So as we looked at this process, however, it turns out it's not so simple. And this slide is up here mainly to show the many steps that had to happen for an outpatient clinic or another health facility to sign a contract with social health insurance so that it could participate in the reimbursement program for social health insurance, and then be able to actually exercise that program, submit and get reimbursed for treatment. And so it turns out that this process is pretty daunting for the clinics that have to sign up for the system and then be able to get reimbursement. So we work very intensively with the OPCs, and we are able to really, I think, quantify our results. If you look at the bars on the left, those are the OPCs where PEPFAR is not working, and the bars on the right are the OPCs where PEPFAR is working. And as you can see, we have 60% of the sites having their contracts for social health insurance, and 30% of them actually being able to get reimbursement. So, and as opposed to much lower levels for the sites where we're not working. So I think we were able to show that we really had impact. One of the key elements in making the social health insurance work is the political commitment from the government of Vietnam to really devote resources to this. And not only the central government, but the provincial governments have also shown really strong support. And these are documents that show a couple of provinces where they have committed their own provincial funds to enroll their ARV patients in the social health insurance fund to cover co-pays that are needed under the social health insurance program. And so this will strengthen the whole system. The other issue that is complicated is we moved from the model where people can go to the OPC and just get their free treatment, which everybody liked, to a system where patients had to be enrolled in the social health insurance, had to be at a clinic which was linked up with the social health insurance program and be able to pay co-pays, was that a number of patients had to transfer as part of this process. And so this is just one case study that where we worked very, very closely with the district health center in this Phan Huong district. For reasons that are too complicated to explain here, this health center was not going to be eligible for reimbursements, and so more than 700 patients had been transferred to the district hospital. So in 2016, we worked very intensively with the district. PEPFAR built a detailed plan to transfer patients systematically. There were monthly meetings with PEPFAR, the health center, and the district hospital to which they were being transferred. We identified issues, we looked at late appointments. The district also pushed out the distribution of ARVs to become in health stations, which made it easier for patients to access their treatment. As a result of our combined efforts, we had quarterly loss to follow-up and mortality of less than 1%, and by December of 2016, only 8 of the 831 patients transferred were lost to follow-up. And so we were very pleased about these results and show that the way that we were able to work together with our Vietnamese partners has really enabled us to make great strides in the past year on making the social health insurance a key component in getting treatment to people. And now Dr. Huong.
Good afternoon. And from pilot to policy and practice, we have been pilot many models such as PrEP and self-testing, lab testing. And today I'd like to share with you one of the examples on self-testing following the latest WHO recommendation. So here is a picture of the US Ambassador Ted Osios. He spoke and director of the Vietnam Authority of Disease Control and Ministry of Health, Dr. Van Long, and CSO MSM representatives attending the launching of self-testing services in Ho Chi Minh City. And the event attracted great media and social attending and brought people from different sectors together. So here is a primary result from our study conducted in 2015 to assess acceptability, user preference, and willingness to pay for HIV self-testing among female sex workers, MSM, and IWIT in rural and urban areas of Vietnam. You may see in the left side of the slide the high attention to use in blue collar self-testing. On the right-hand side, even higher in the willingness to pay in red color among key population. This was a surprise to us, that both KB in rural and urban are willing to pay at the cost around $2 to $5, although the cost for the oral test is still higher than ability to pay, so it would take some time for it to be able to scaling up in Vietnam. So please look at the cascade of the self-test result in just a half of the year, which show high reactive rate of more than 8%, and there is no significant difference in competency between self-tester and health sector and health worker. The successful linkage to treatments especially high. You can see that it's 98%. And the diagram on the left show evidence that this new testing approach is highly relevant, with around 53 to 87 people getting tests for the first time. And after the successful pilot in 2016, this year the model is being multiplied to 15 provinces and scheduled to roll out nationally in 2020. And we are now working closely with the manufacturer to make the product available in Vietnam market so that it will be accessible for the people who have demand. PEPFAR is supporting us to developing the national guideline to be issued nationally to ensure that the sustainability and quality of the program. So thank you very much for your attention.